So today I'm going to talk about a patient. She's a 26-year-old female with medically refractory epilepsy. Seizure started at the age of 7. She has two seizure types. The first type, she has preserved awareness by cycling motion of her right leg, torso, and then arm. And it lasts and she gets it about once a week, lasts about 30 seconds. The second type, she's had only 3 of these in her lifetime till she came and saw us, and these were generalized tonic-clonic seizures. She's tried several medications in the past, was on 2 AEDs or anti-seizure medications when she came and saw us in 2020. Her MRI was normal. She underwent further diagnostic workup. We brought her to the EMU. We found 4 seizures on scalp evaluation. They were possibly coming from the left frontal region. She had a normal neuropsych testing, and we presented her in surgical conference, which we have every Friday, where the decision was unanimously made to have a left frontoparietal intracranial implantation with stereo EEG. So just briefly, I'm going to show you guys her implantation. She had 11 electrodes. 6 of these were from ventral to dorsal, and 5 of these were medial to lateral on the left side. This is just an example of what a stereo EEG electrode looks like. You can see it's a thin needle, and it has several little electrodes on it. We captured several seizures while she was here. Just to give you an example of one of her seizures, you can see there was a change in background, and you can see this flat and really dark looking activity on the EEG, which is actually fast activity, which is what we look for in stereo EEG. I am going to show you, so these are 2 electrodes of interest, which I'm going to just show you over here. These 2 were the electrodes, and red is where her seizure was coming from. Now, I am going to show you a video of this patient. So we stimulated areas that were close to where her seizure was coming from, and we found this. And I'm going to go really slowly. So by stimulation, I mean we passed electrical current artificially from outside through those electrodes. So on passing that current, you can see her right arm moved up, her right elbow, which indicates that there was motor function in that area. Let's see if I can get the other one to play too. It's a little slow because it's an old recording. So you want to look at the video on the right more carefully. And you can see on passing electrical current through these electrodes, which were 7 and 9, her eyes move to the right, as does her head, which indicates motor control of her eyes and head is located close to or at right where those electrodes were. So to give you a perspective, this purple area was where we stimulated, and that's where her arm control, her eye and head control were. Some other stimulation was done posteriorly, which had maybe a little bit of leg control. We also did somatosensory evoked potentials. Similarly, we passed electrical current from the median nerve, goes to the brain, and you can record that on the stereo EEG electrode. So I'm going to show you a side-by-side comparison. So this is where the seizures were, which is right here. And this is where we did the motor function mapping, and this is the sensory function mapping. So everything was very closely located, the seizures and the motor and sensory function for this patient. Needless to say, she was not a good resection candidate because that would leave her paralyzed. The recommendation was to offer non-resective strategies, neuromodulation techniques such as vagal nerve stimulation or responsive nerve stimulation. Given these were so focal, we decided to go with responsive nerve stimulation, or RNS. She has improved seizure frequency, but we're still adjusting because it's only been about 7 to 8 months since she got the RNS. This is the patient's RNS. You can't really see it very well, so I got you a schema These are electrodes, and you can see the patient's electrode located on the surface of the brain. The RNS sits right here inside the skull, under the skin, and the electrodes come out from the RNS and they stimulate the area of the brain where we think the seizures are coming from. So what is RNS? So it's a responsive neurostimulation. So it monitors electrical activity, it detects the seizures, and it responds once it detects the seizures. It sends electrical current. And it is FDA approved for focal seizures for adults over 18 years of age. And we have been using it quite frequently over here at Duke as well. That's about it. Thank you.
Thank you, Prachi. And to introduce our grand round speaker, I'm going to throw it to Atif.
Thanks very much, Rich, and thanks for the opportunity to have an epilepsy topic in grand rounds. So it's my pleasure to introduce Alex Rotenberg, and you'll see that Alex's presentation will tie in nicely to Prachi's. Prachi talked about two topics that Alex will hopefully also touch on, and that's mapping and neuromodulation and epilepsy. So first, a little bit about Alex. Alex probably does not remember this, but he and I first met on a bus in Guadalajara. We were both at a Mexican neurophysiology meeting. We weren't randomly in Guadalajara enjoying ourselves, but that's the first time I met him a number of years ago. And since then have been extraordinarily impressed with the kind of work that he's doing and the kind of treatments he's offering his patients. Alex went to undergraduate at Johns Hopkins, then medical school in SUNY Brooklyn, did a pediatric residency in Mount Sinai in New York, and then moved up to Boston Children's to do his pediatric neurology residency and then fellowship as well, and has stayed on at Boston Children's since then. Alex currently is a professor of neurology at Boston Children's Hospital, and he is the director of the neuromodulation program within the Department of Neurology. He's also recipient of many awards, including the Dreyfus-Penry Award for Epilepsy that the AN gives out for excellence in epilepsy research. He is also the past president of the Greater Boston Area Epilepsy Society, and his research interests focus on neuromodulation, non-invasive neuromodulation, specifically TMS and TDCS. Some of which I hope you will talk about. The topic for today's discussion is going to focus on using non-invasive brain stimulation, TMS in particular, for mapping. So as Prachi pointed out, we have several ways of mapping patients, both in epilepsy for resective surgery, but also for other types of surgery, such as brain tumor surgeries, where the lesion may be an eloquent cortex. This mapping in epilepsy can certainly happen with electrodes implanted, as Prachi pointed out, but obviously patients with brain tumors and other types of lesions do not have electrodes implanted, and we often will need to map them in the operating room, which sometimes when we're doing language mapping involves waking patients up, which can get very complicated very quickly. And so the purpose of today's talk was to investigate other ways that we can accomplish this type of mapping and whether we can provide our colleagues, the surgeons, with additional information about eloquent landmarks. And then also talk about neuromodulation in epilepsy, which is an extraordinarily growing field. At our own center, Dr. Parikh and Dr. Sinha are the two primary people leading the charge for neuromodulation. The one thing we have not started doing is using TMS for epilepsy, and Alex will introduce us to that topic. We are on the verge, hopefully, of acquiring such a unit, and so this is an opportune time to listen to Alex. So thank you, Alex, and we look forward to your talk.
Thanks, Atif. Thanks very much for this opportunity to talk about TMS. I'll share my screen, which hopefully is now visible.
Yep, it's visible.
So, actually, mentioning RNS is an interesting intro into the topic, which is I'd like to zoom in on the diagnostic capacity of TMS and the means to map functional cortex. And TMS actually stands out among other neuromodulation gizmos in that it has a plausible therapeutic capacity, and it's FDA cleared for treatment of major depression, for example, and in trials for suppressing seizures, but actually has a very realistic role as a diagnostic tool, especially for mapping eloquent cortex and mapping function relative to the anatomy of a lesion. And this diagnostic capacity is not really talked about very much in neuromodulation, just because even the term modulation implies something therapeutic, but between the lines in the RNS is a capacity to track seizures, and more means to deploy technology to measure cortical excitability or measure seizure susceptibility is really becoming an entity in epilepsy. And so that's what I'd like to focus on is the interesting diagnostic role of TMS, but specifically for functional mapping of the cortex. And just by way of introduction to TMS, as a quick summary, just for those who may not be familiar, the M in TMS is a little bit misleading. It is in fact not a magnetic form of neuromodulation. There is a rich field of study in identifying how magnetic fields interact with the central nervous system, but TMS is a way of electroless electrical stimulation. It's ultimately a means of focal cortical stimulation that's based on Faraday's principle, the right thumb rule from physics. And in fact, if you're in London and you want to skip the boring tourist attractions like Big Ben and Parliament, you can zoom in on a really cool part, which is the Faraday Museum that actually has in it some of his original inductor coils. And these 1830-something experiments have been embodied in now a medical device where the mechanics of TMS are relatively straightforward. There is a handheld electromagnet that's applied to a patient's scalp. That magnet generates a magnetic field in MRI territory, about 1.5 Tesla. And that magnetic field fluctuates over about 1/4 of 1 millisecond. And that fluctuation of the magnetic field induces electrical current everywhere around it, including in the brain if the nearby conductor happens to be the head. Now, the most eloquent part of the cortex to stimulate, and you can see here, this is actually the first TMS device, is the motor strip, because it talks back to the operator. So here, the operator is stimulating the right hemisphere of this patient while this patient has an electrode on the left palm. And from that electrode, one can generate and record a motor evoked potential. And that gives us scientifically something interesting. One, it lets us identify the amount of energy that needs to be injected into the cortex, the strength of the magnetic field that's above threshold to activate the motor cortex. And then because the motor evoked potential can be quantified in terms of its amplitude, or with more interesting protocols, its paired pulse inhibition or its modulation with repetitive stimulation, we can actually have access to an input-output curve, which physiologists use quite a bit for in vitro studies, but now in a walking, talking patient, and we can actually measure cortical excitability. The optimal settings for TMS enable relatively focal stimulation to about 0.5 centimeter on edge voxel with an electromagnet. And these TMS devices really haven't changed much in the 30 years that they've been available. This is the first device made by Tony Barker in the early 1980s. These are Natasha and Gabby, our secretary NRA, using a more modern device where the newer innovations are a few. Some of these are visible in this photo. One is actually the capacity for infrared reflectors to be attached to a participant and then to a TMS coil so that a stereo camera can keep track of the positions of both of these. And then with frameless stereotaxy, project where the electric field will be landing on the patient's cortex using a patient's reconstructed MRI. The other innovation you can't quite see because it's enclosed by the casing, but that has to do with the shape of the electromagnetic coil. There is a range of electromagnetic coil configurations that can be used. And the most common one that's used, especially for mapping functional cortex, is what's called the figure-of-8 coil. In a figure-of-8 coil, two adjacent Archimedes spirals are conducting electrical current, so that what happens in this butterfly-shaped current coil is that electrical current in the two lobes moves in opposite directions so that it sums at the center. and maximizes the amount of the electric current at the center of the TMS coil. That maximizes the magnitude of the induced magnetic field, and that necessarily maximizes the amount of induced electrical current inside the cortex. Bottom line is that with this figure of 8 configuration, one could have a relatively focal stimulation. So notwithstanding that in this image, for example, the magnetic coil is about the size of a palm, the business end of the coil is really just its very center, and that translates to only a relatively small amount of cortex that's stimulated. The other innovation relative to 30 years ago is the introduction of frameless stereotaxy, where a participant's bony landmarks can be registered to a frameless stereo camera in a computer, as can rigid parts of the TMS coil. And then the operator in real time can have feedback from a stereotaxy instrument as to where the induced electrical current should be anticipated on the patient's own anatomy. And so this is these are all images from publications of representative frameless stereotaxy TMS setups. Our setup looks like this. This is Stephanie, another one of our admins. Our admins and the secretaries are keen to volunteer for these things. But this is a typical setup in our office where we have the stereo camera, a reflector, a pair of reflectors on the patient and on the TMS coil, a monitor that enables the operator to in real time see where the coil is positioned. And what's not very visible here are electrodes attached to pre-selected muscle groups on a patient. In our case, we have 6 amplifiers that enable us to record 6 EMG channels simultaneously. And the electrodes themselves are not very bothersome. They're all surface electrodes. They're typically placed on a muscle and then a reference region on the patient's limb. This can be done across ages. And with only a few accommodations, we can actually manage to record motor rogue potentials while stimulating the motor cortex in patients as young as age 7 months. This is actually a child a little bit under a year old. Both of these parents, by the way, consented to have these photos shown. This is a child with a focal cortical dysplasia, where in both cases we've had to replace our adjustable chair with a mom. And in both cases, the children are somewhat puzzled by the electrodes and the magnet, but they're not particularly disturbed by it. In fact, we actually have setups because we're in a children's hospital, to have out of the edge of this photo, an iPad that plays a cartoon while the patient is stimulated. But this is my long way of saying that TMS is actually a well-tolerated procedure, particularly for motor mapping. So with any kind of neuromodulation, the stimulation protocols can be coarsely divided into 3 types. One is single pulse stimulation, where a single stimulus is delivered to a region of the nervous system and a single evoked response is measured. And the magnitude of that response can be coupled to the magnitude of the stimulus, so we can actually measure cortical excitability that way. There's a very interesting protocol that's available, again, with any kind of electrical or electromagnetic stimulation, termed paired pulse stimulation, where an individual stimulus, a conditioning stimulus, is delivered to the cortex shortly before a second stimulus called a test stimulus. And this modulation of the response to the test stimulus by the conditioning stimulus enables very interesting measures of regional cortical inhibition. And we won't have time to talk about this, but this, again, as you can imagine, a disease like epilepsy, where a paucity of intracortical inhibition might be part of the pathophysiology, is something that interests us quite a bit in research. And then there's the kind of stimulation that the RNS device uses, or TMS could deploy, which is repetitive stimulation that can either disrupt an ongoing event in the cortex, or if it's delivered over and over again, can modulate cortical excitability by mechanisms that very closely resemble long-term potentiation, long-term depression, the mechanisms by which we actually store or lose memories. And I'd like to zoom in on this particular type of protocol right now, just single pulse stimulation, because that's the low-hanging fruit. This is the FDA-approved protocol for functional motor mapping by TMS. That is that this is the means by which we can stimulate the cortex in a predetermined region record the motor evoked potential, and then generate a functional motor map. This is a patient from the Brigham and Women's Hospital from a few years ago with a ring-enhancing lesion, where the question was, where is this patient's motor map relative to this patient's lesion? So the protocol from the operator's perspective looks something like this. This is a reconstructed MRI of a 4-year-old. The operator is adjusting the coil until she or he sees the image that looks like this. The junction of the red and blue arrow correspond to where the center of the coil is positioned relative to, in this case, this patient's precentral gyrus. And what the operator and the computer see are 6 channels of EMG, where on only a single channel, in this case, there's a conspicuous deflection, and this corresponds to a motor evoked potential strictly from the adductor pollicis brevis muscle in the right hand, with this stimulus delivered to the left hemisphere. The other 5 channels of EMG are silent, and that gives us a sense of the spatial selectivity of TMS. That is that this orange channel, you have to take my word for it, happens to be the deltoid on the right side, and you can see that the deltoid is silent while the intrinsic hand muscle is giving us a motor evoked potential. The product that we use in a weekly epilepsy surgery conference, for instance, looks like this. This is a map color-coded with the amplitude of the motor evoked potential for the right hand intrinsic muscle for this patient. So we can say safely that this patient's right hand motor cortex representation is confined to this region of the left precentral gyrus. Just like we map the hand muscle, we can also map the foot. And for example, in the same patient, the tibialis anterior appears roughly here. The spatial specificity of TMS approximates that of fMRI. And interestingly, this was actually part of its FDA approval, was showing a non-inferiority of TMS, and in the sense for navigated TMS mapping in terms of spatial precision to functional MRI. And you could see already here, actually, that notwithstanding that this is the same set of patients, and I think the same individual, where fMRI and TMS both mapped, in this case, an intrinsic hand muscle, the representation appears a little bit different, with a slight posterior drift of the fMRI. And this is an interesting element of functional mapping by fMRI, which is that the motor map by fMRI is rarely purely motor. That is, there's necessarily a somatosensory signal that comes with movement, or a proprioceptive signal that comes with movement. And that necessarily involves components of the cortex that are a little bit behind the motor strip. And so it's not infrequent that when we compare a navigated TMS map to an fMRI map, what we have is a slightly anterior position of the map that we obtained by direct electrical stimulation of the cortex relative to the fMRI vascular surrogate of the motor map. That's kind of an aside. But nonetheless, in terms of how close are we by TMS to fMRI mapping, it's at least non-inferior, and in some perspective may have a few advantages, because it really does approximate what we can also map in the operating room. When we've had opportunities to map the motor cortex with grids and previously map it with TMS, this has actually matched. So here's a concrete example of how we can use TMS. This is a motor map. So this, as you can see, is a contour map generated from these individual points, a heat map of the motor evoked potential amplitude, in this case, the first dorsal interosseous muscle, as a surrogate for intrinsic hand representation, in a patient with a low-grade glioma, which you can see is actually effacing the cortex here, was just under the motor strip. So we're able to effectively map this patient's intrinsic hand motor cortex representation. At the same time, we could map the tibialis anterior in this patient and have a handle on where the foot representation is, and then put these images together to find a corridor between the foot and hand representation, where our surgeon, Lily Gundarova, could go in and carefully remove this tumor via the precentral gyrus without disrupting either foot or hand function in this patient. This patient actually did very well. She was able to drive, dance, etc., with this motor cortex surgery. interestingly enough, just in the day-to-day pre-surgical mapping before epilepsy surgery, we get a byproduct. That is, that we get actually an intellectual byproduct. And that is the capacity to learn something about the motor map organization in epilepsy and in specific epilepsy syndromes, and to see perhaps how epilepsy may affect the motor map. So one of the interesting elements that we see is how is the map organized in disorders of cortical development. So here is a patient you could see with this axial, a tuberous sclerosis patient, where the crosshairs are around a specific tuber. This tuber happens to sit like a cataract in the central sulcus of this patient. And the conventional wisdom for me was quite a bit that tubers are relatively inert in terms of their connectivity, except for those rare instances where tuberectomy in tuberous sclerosis would lead to very conspicuous deficit. And interestingly, in this individual, we mapped the motor cortex. And what we found was that almost the entirety of the left deltoid motor evoked potentials in this patient and the left tibialis anterior motor evoked potentials in this patient were derived with stimulation of this tuber and not with stimulation of the nearby cortex, apart from a few outlier points. To see that we weren't just lucky or the map wasn't off, we actually asked a colleague to seed for purposes of tractography, specifically this tuber. And indeed, there were corticospinal tracts coming from the tuber that had this physiologic motor connectivity. So here's something interesting, again, sort of an intellectual byproduct that we can have in doing the everyday mapping of the motor system relative to a patient's seizure onset zone. That is, we see how the motor system behaves in specific diseases. And there's something interesting about this finding for us, which is at the molecular level, cortical tubers and lots of malformations of cortical development reflect a dysmaturity. And what we may be seeing here is not so much an aggregation of the motor system to the tuber, but an absent maturation of cortex, where the motor corticospinal representation, which in development is actually pretty diffuse and then consolidates to the precentral gyrus, is actually not released by this tuber. But whatever the biology of this, we get these insights from mapping the motor strip before epilepsy surgery. And now what else is an interesting value added of doing pre-operative motor mapping non-invasively is the capacity to map the contralesional hemisphere. That is, that for us to map a lesional hemisphere is ultimately 1930s technology. That is, to stimulate something near a lesion and then see what moves. Is something that could have been done in the operating room a long time ago. It could be done extraoperatively with grids and strips. And it's certainly a utility for us to be able to do this non-invasively, but it's not that big a trick. But what's unavailable to us in the operating room, you can actually see this patient with a previously operated on hemisphere with a motor map in the right hemisphere, is the capacity to map the good hemisphere. In other words, that one is never open, that one doesn't have grids in it. And this becomes valuable to us when we want to see whether or not, in cases of a lesional epilepsy or any kind of unilateral lesion, where there might be a motor disconnection, there is corticospinal reserve in the other hemisphere. So this is one such example. Here is a patient with a left-hand map in this very lesional hemisphere. And in the left hemisphere, there are separately a right-hand map, and I hope it shows that's a little bit faint here, is also a left-hand map. And this actually does provide to us a value add for doing this non-invasively. That is the capacity for us, before a patient who has for hemispherectomy, for example, to map the motor representation in both hemispheres and forecast whether or not a disconnection of a hemisphere will still leave us with some motor reserve in the contralesional hemisphere. And here's one of these examples where a child was headed toward a hemispherectomy, and the arrows here just mark the sites where we stimulated. You can see this is kind of a hemimegalencephaly. It's a grossly malformed hemisphere for a patient who was had seizures bad enough to disconnect the entire right hemisphere in this case. And with stimulation of the contralesional hemisphere, we saw something interesting, which is valuable for us in this patient's case. That is that we could see that a single stimulus to the contralesional hemisphere produces motor evoked potentials from the left and right hand. In this case, it was the first dorsal interosseous motor evoked potential. There's, as an aside, something cool about this stimulus, which is you could see where it lands. It's behind the central sulcus. And it turns out that if we do TMS or if we do motor mapping by grids often enough, we see that more often than not, there's at least some corticospinal representation behind the central sulcus. We're not the only ones to see this. Harry Shugani, more than 10 years ago, actually published a paper showing that especially in young and healthy adolescents, there's an appreciably amount of the corticospinal tract that originates in a post-central gyrus. And when we do TMS behind the central sulcus, more often than not, we could find a few spots of a corticospinal tract. That's my long way of saying, as an interesting aside, that the homunculus cartoon is just that. And the segregation between the motor and sensory cortex is not really 100%. A biologically more accurate way to think about that entire region is the sensory motor cortex with strong biases toward motor representation in front of the central sulcus. So back to this kid. When we stimulated the lesional hemisphere, we saw nothing but stimulus artifact. That is, we have a relatively favorable scenario in this patient who's headed toward hemispherectomy, where stimulating the good hemisphere gives us motor evoked potentials on both sides of the body. Stimulating the bad hemisphere gives us nothing. So for better or worse, this patient was actually cooperative enough to go for a functional MRI. And so when you do an unnecessary test, you get an unnecessary result. We brought this patient in for a functional MRI, and I'll just point your attention to this bottom right panel, where with a left hand tapping task in this very malformed hemisphere, we had a very conspicuous bold signal. So now we have a discrepancy. By TMS, with stimulation of what we think might be a motor area, we don't have any motor response. That is, we have no corticospinal activation with electrical stimulation of the cortex. But by fMRI, we have a very clear, bold signal in that same hemisphere. Now, it turns out that after the hemispherectomy for a disconnection for this patient, he didn't have that much of a motor deficit. He didn't gain any motor deficit. And we're not the only ones to see when there's this kind of discrepancy between the fMRI and TMS, that the TMS is in fact a good predictor of a subsequent motor deficit. So this is a small series of patients with hemispheric polymicrogyria who all had hemispherectomies from Martin Stout's group in Germany, who had the same kind of discrepancy. That is, some of these patients had absent sign of corticospinal activation by TMS, by electrical stimulation of the corticospinal tract, but preserved fMRI signals. And then none of these patients lost any motor function with disconnection. So this kind of discrepancy underscores a couple of interesting things. One is, it tells us that in comparisons between fMRI and TMS, an absent corticospinal signal by TMS is a better predictor of subsequent absent motor deficit than a present signal by fMRI is a predictor of subsequent deficit. The other tells us something about just the distinct physiologies of what we're measuring by TMS and fMRI. TMS really is a very direct measure of corticospinal connectivity. We induce electrical current in the cortex and we receive a motor evoked potential, and it's a very unambiguous signal. The fMRI bold signal is much more complex. It's ultimately a vascular surrogate, and it could be that we have this vascular signal in the cortex, maybe because the cortex is preparing to send a signal, but the layer 5 output of the cortex is absent. Or it could be that what we're seeing is a thalamocortical signal, which tends to be bilateral in patients, and we're seeing segments of a somatosensory or proprioceptive signal, but not necessarily a motor signal that's associated with movement. Whatever the case, we do have these interesting discrepancies in motor mapping between what the fMRI shows and what TMS shows. And in these instances, TMS turns out to be a better predictor of actually the position of the motor map, and two, the likelihood of motor deficit after a large disconnection that will include the would-be motor areas in a hemisphere. Now, this was a quick drive-by through single pulse stimulation and its role in motor mapping. And now let me show you repetitive stimulation and its use for language mapping. And so much like the RNS can disrupt an ongoing seizure, you can imagine that a train of repetitive stimulation by TMS can disrupt a cortical event. And if it's delivered to Broca's area, it should disrupt expressive language. So what this video shows is the operator, me in this case, and I'm actually wearing a watch here that I've stopped wearing because it started running slow. And I think because of this exposure to the magnet all the time. And what's happening here is that I'm looking at a monitor that's showing me the relative position of this coil, and I'm navigating it to pars triangularis in the left hemisphere. The participant is looking also at a monitor. His monitor is flashing any one of these things, an arrow, a pair of binoculars, a flower, and his job is to name the object as soon as it flashes on the screen. So I hope this audio and video work. Please let me know if it doesn't. And watch what happens.
Arrow.
So, oops, he sees an arrow and he says arrow.
Arrow.
Arrow says arrow.
Binoculars.
Says binoculars. Oh, he sees a flower. Let me play this again. He sees a flower and he says nothing.
Arrow. Binoculars.
He sees a flower. He smiles, so his face is not paralyzed.
Arrow. Binoculars.
And of course, in a control condition,
Flower.
he knows it's a flower. And he's smiling here, so we can see his face is not paralyzed. If you actually ask him his subjective impression of what happened, he thinks it's kind of silly. He knows it's a flower, but he couldn't get the word out. And this was a 1 second long Broca's aphasia produced with stimulation of Broca's area in this patient. And so just like we can map the motor cortex, we can generate a region where we can stimulate and produce a language deficit in a patient. And interestingly, a little bit like a comparison between fMRI and TMS for motor maps, there are sometimes discrepancies that we see. We see these actually in our line of work, maybe disproportionately more often because we work with children and whose fMRI often has to be a sedated fMRI. And interestingly, in a sedated fMRI with light sedation, if a child hears a story in their native language, there is a little bit of Broca's area activation. And so our fMRI group uses this for motor mapping sometime, language mapping sometime. And what we have here is one of these examples. Here is a young girl who listens to a story passively in Polish. You can see actually the auditory activations here. And this is the single region corresponding to Broca's area activation and on the right hemisphere, an absent signal on the left. And the official read from this fMRI was that this patient has right hemisphere dominant language. I should say that this patient has a left inferior frontal cortical dysplasia that you can see here with the blurring of the gray-white junction. It turned out by TMS, though, when we stimulated just beneath this dysplasia, we had a very conspicuous language arrest. Not only that, one of the risks of stimulation is that we can induce a seizure, especially with the kind of repetitive stimulation that we do for language mapping. And sure enough, in this patient, we induced a seizure actually with the stimulation of the inferior part of the motor strip. And the first sign of her seizure clinically was language arrest, expressive language arrest. And so we actually identified in this patient, notwithstanding an absent bold signal, an active area of language just beneath the cortical dysplasia, and confirmed, just like the fMRI, that the patient also had some right hemisphere language representation. So again, the interesting component that we saw in this case is that there's a discrepancy between the fMRI and TMS in this case might have been a better predictor of a language map because it really does for purposes of mapping before surgery, provide us with a virtual lesion. That is, we're disrupting a region of the cortex to ask what would happen if this region were offline. And it turns out that particularly when the fMRI points to the right hemisphere, and there's a discrepancy between the fMRI and TMS, so that TMS points to either the left hemisphere or TMS indicates bilateral activation, and we look at things with invasive monitoring, TMS again is a better predictor of the lateralization, at least of expressive language. So that's the quick summary of what's so good about TMS for language and motor mapping. And I won't belabor the point, but to say that we have this interesting motor maps of the lesional and contralesional hemisphere by TMS that identify for us quite often that, notwithstanding, you can see this child with a large perinatal stroke and encephalomalacia with spots of activation in the lesional hemisphere, but pretty robust bilateral hand representation in the good hemisphere, that what we have is this interesting intellectual byproduct. That is, that we can see that there is a preserved bilateral corticospinal innervation in the good hemisphere in many patients whom we map. Now, in common jargon, we sometimes would say that there has been a remapping after an injury to a hemisphere so that the contralesional hemisphere now has bilateral motor representation. The more accurate way to think about this, though, is that there is preserved corticospinal connectivity in the contralesional hemisphere. That is, that we are born with both hemispheres having a pretty robust bilateral corticospinal connectivity to both sides of the body. And through maturation, there is gradual suppression of the ipsilateral connections. So that by around age 2, there's predominantly contralateral innervation from each hemisphere. And this can actually be studied by TMS. And this is a graphic from Jane Eerie's paper from about 20 years ago, where she studied normal newborns, including her own, and newborns who had an MCA stroke, and with stimulation of the infarcted and non-infarcted hemispheres. And the graphic here shows the biceps motor evoked potentials generated with unilateral stimulation. And the dashed line corresponds to the contralateral biceps from where the coil is positioned, and the solid line to the ipsilateral biceps. And what we can see in a normal newborn at birth, there's actually pretty robust bilateral connectivity, essentially equal size of both biceps motor evoked potentials. And through age 2, there's gradual suppression of the ipsilateral with essentially nothing but contralateral biceps left. Interestingly, in the contralesional hemisphere, for a newborn that's had a stroke, a perinatal stroke, there is absent suppression of this ipsilateral signal. And so the scenario that we have with stroke is that, in contrast to the healthy scenario, where the bilateral corticospinal connectivity is pruned to predominantly contralateral, by a signal that we don't understand, there is an absence of maturation of corticospinal connectivity in the contralesional hemisphere. Now, this absence of maturation is compensatory in cases of stroke. But what we see in epilepsy is something else that's really interesting. And let me show you the example. Here's a patient of mine with a low-grade glioma with, interestingly enough, notwithstanding her right hemisphere lesion, seizures that started with right arm tonic extension. So right hemisphere seizure onset zone, right motor seizures. Sure enough, when we delivered a stimulus by TMS already many years ago to this patient's precentral gyrus, we produced robust right hand motor evoked potentials. So we have an interesting scenario here. In contrast to what we think is a compensatory event, something signals the contralesional hemisphere after a neuroclastic process, a stroke, let's say, to not undergo the natural maturation and maintain the ipsilateral corticospinal connections. Something interesting happens in epilepsy where there is, we think, pathological maintenance of corticospinal connectivity in the lesional, not contralesional hemisphere. And we see this over and over. Here's another example where you can see actually this patient's seizure onset zone was resected. where in the precentral gyrus, with one stimulus, we have a right hand abductor pulsus brevis motor evoked potential. With a nearby stimulus, we have a left hand motor evoked potential. And if we color code left, right, or bilateral in this patient, we have a mix of sites where we can elicit left, right, or bilateral hand activation with electrical stimulation of the cortex. It turns out that if we look at patients not for hand motor representation, but in this case for tibialis anterior representation, so that we have in an individual in one hemisphere bilateral tibialis anterior representation and in another hemisphere unilateral, and we ask, in the scenarios where there is preserved bilateral corticospinal connectivity in only one hemisphere in an individual, what is the probability that that hemisphere contains the seizure onset zone? It turns out that probability is north of 95%. So the scenario that we see, again, as an intellectual byproduct for doing motor mapping before epilepsy surgery, is in contrast to the healthy pruning of the ipsilateral corticospinal connections that occur with maturation, and in contrast to the compensatory preserved immature connectivity in the contralesional hemisphere after stroke. In epilepsy, for reasons that are not at all clear to us, what we have is an dysmaturity, a preserved bilateral corticospinal connectivity in the lesional hemisphere. Why this happens, we don't know, but one could argue a few ways. One is that it could be that this suppression of corticospinal, of ipsilateral corticospinal connectivity is use dependent. And in a hemisphere that's firing all the time, that has interictal spikes, that has seizures, there is use-dependent maintenance of myelination or use-dependent maintenance of excitatory connectivity. Or it could be that some of this maturation-related suppression of ipsilateral connections is cortical and based on a maturation of inhibitory tone within the cortex. And inasmuch as epilepsy could be a disease of insufficient intracortical inhibition, maybe what we see is that there's just not enough inhibition to go around to suppress these ipsilateral connections. Or it could be some combinations of these. Experimentally, again, without doing dedicated experiments, but just looking at our preoperative motor maps for patients with epilepsy, we have at least a little bit of insight that some of this could be a matter of use-dependent myelination. Why do we have this? Because the motor evoked potential that we generate relative to the stimulus time could be quantified in a few ways. And one is to quantify its latency. And what we see quite often is in patients where we map the motor cortex in the healthy, well, let's call it healthy for now, the contralesional and lesional, let's say, hemisphere. In the hemisphere that contains the seizure onset zone, the latency of the motor evoked potential tends to be about a millisecond shorter. And this suggests to us a possibility that the physiology of what we have in this process of maintenance of the ipsilateral cortical spinal tract has to do a little bit with use-dependent maintenance of these tracts, perhaps use-dependent myelination, because it's ultimately myelination of the cortical spinal tract that's responsible for this latency. And when we measure these, we actually see that overall, the affected hemisphere has on the y-axis here is the latency of the motor evoked potential, has slightly shorter latencies of the motor evoked potential. And actually that gradient between the hemispheres, and on the y-axis in this graph is the difference between the lesional and contralesional hemisphere in terms of latency to the onset of the motor evoked potential. The latency is greater when there's a lesional epilepsy as opposed to a non-lesional epilepsy. Now, why is this interesting to us as child neurologists? It's because this may not be a compensatory event in epilepsy and may in fact be giving us insight into the disease of epilepsy. And in as much as there is maybe redundant motor connection, maybe there's a necessity now for redundant premotor cortical function, and maybe that corresponds to a little bit of crowding in the frontal lobe that we think could be reflected in some of the cognitive deficits that we see in patients. One way or another, what we're seeing is an immaturity of the motor system at a few levels by doing motor maps for patients with epilepsy. It's an immaturity in terms of connectivity. It's an immaturity in terms of lateralization, and it might be an immaturity in terms of the differentiation of function in a developing frontal lobe. But interestingly enough, by just mapping the motor cortex before epilepsy surgery, we are in position to formulate these hypotheses and maybe even test them. So that's, again, a quick summary of what's so cool about motor mapping. And I just want to finish with a couple of slides just to pitch TMS as something that's spilling out of the healthy normal anatomy to unusual heads and unusual brains. And so more and more TMS could be done in patients with some hardware in their skull. And this is interesting to us because when we're generating a fluctuating magnetic field, we worry about induced current, for example, in skull plates that may be holding down a craniotomy, or what are called Lorentz forces, which are the mechanical interactions between a conductor that has some amount of electricity in it and the magnetic coil. This causes objects to bounce appreciably. And we can actually test whether or not TMS is safe in patients who've had a craniotomy by doing junior high school tabletop physics. So for example, we can take these objects that would otherwise be found near a TMS coil and put a thermocouple on them and test whether or not they heat appreciably with repetitive stimulation. So in contrast to a conventional EEG electrode that heats to injurious temperatures, with TMS, it turns out that titanium skull plates do not. We could actually measure in newtons how much force is exerted on them. It turns out that it's not enough to make them move. And so we can test these things preoperatively. And we can actually also model for us what happens when we do TMS in unusual anatomies. And one interesting element to consider is more and more we'll be dealing with patients who've had an early life stroke or an early life surgery or another neuroclastic process where there will be an appreciable amount of CSF through which the induced current could be shunted. And so this is actually work of Tim Wagner from years ago to identify how TMS current, so current density on the y-axis, is distributed in skin, scalp, CSF, bone, brain, etc., for purposes of modeling where in a patient with stroke the TMS induced current might be distributed. And what we have here is actually something that's relevant to us for purposes of motor mapping. That is that if we deal with unusual anatomies, the topography of the motor map has to take into account the intracranial anatomy. And so let me explain this with a graphic. So here's, for example, this red deflection corresponds to a right deltoid motor evoked potential that's obtained with stimulation of this region in the patient. Now, this patient who had a perinatal stroke, and you can see the encephalomalacia here in a CSF cavity, with stimulation in the CSF cavity has the same motor evoked potential. And it's not that CSF is biologically active. What it tells us is that current, induced current in this volume conductor of CSF is probably distributed to its edges. And it tells us that at least an edge of the CSF cavity is touching the corticospinal tracts that could otherwise be activated by this cortical stimulation. So that when we consider the topography of a patient's motor representation, we actually have to consider to some extent the physics and particularly the amount of CSF that may be in the way of us generating this map. Anyway, that's the quick summary of how we do TMS and what's so productive scientifically and practically about doing TMS functional mapping before epilepsy surgery. So I just want to close with this photo of Jacques Sandor-Sanval, who made one of the earlier TMS type devices, which was a test of whether or not induced electrical current could produce CNS effects in an individual. And sure enough, when they ran current through this coil, this individual experienced dizziness, vertigo, etc. But the cool part about this photograph is not the early attempt at transcranial magnetic stimulation, is who these people are. And so what I heard is, from this photograph is that this guy is the laboratory technician running the equipment. And the person who's putting himself inside the coil is the lab's postdoc. And Jacques Sandor-Sanval is this guy standing off to the side taking credit for the whole thing. And so unless you think that I'm doing any of the work that I've shown from our laboratory, I promise you I'm not. It's all the work of our young investigators. So everything you like about this talk is completely their credit, and everything else is mine. So thank you.
Thank you very much. That was amazing. While people are coming up with questions, just either put your question or your name in the chat. I won't be able to notice if someone raises their hands. So Alexander, like with all your work on TMS, have you ever seen any evidence for a long-lasting effect, or is it all just acute activation or inhibition?
By design, we have a line of work to induce a long-lasting effect. And so for purposes of mapping the motor cortex or language, we deliver either a single pulse or a very short train, confined to about 1 second. But for seizure suppression, for modulation of mood, we deliver many hundreds of stimuli to induce a lasting change. And that's in fact another use of
Carolina, can you go on mute? I guess I can. Okay, thanks. But what's your evidence that there is a lasting change?
So the quantitative evidence could be measures of the motor evoked potential. That is, that if we deliver repetitive stimulation to the motor cortex and we measure the amplitude of the motor evoked potential before and after a train of stimulation, that amplitude will change in predictable ways. And so this is a way for us to use the motor strip to actually measure an individual's capacity for use-dependent plasticity. We actually have had already a couple of projects NIH funded to use this as a measure of cortical plasticity in autism, where a lot of the pathophysiology, a lot of the synaptopathology compromises mechanisms of long-term potentiation and long-term depression. So this is a way to quantify it. The clinical way to measure a lasting effect that's most common actually is the effect on a patient's mood after stimulation of the dominant dorsolateral prefrontal cortex. It's the most common way to use TMS for treatment of major depression, and it modulates mood in a predictable way, and the effect lasts a few months. For seizure suppression, we've seen the same. When we've delivered TMS over a seizure onset zone, we have seizure suppression. It's not permanent, but it lasts a while.
Okay, thank you. So we have the questions lining up. Saurabh, do you want to go first?
Sure, thanks, Rich. That was a wonderful talk. Can you get white matter activation if you stimulate hard enough?
We think so. There's actually a couple of experiments suggesting that what's activated is the immediate subcortical white matter. And they come from the optic radiations, where there's a predictable orientation to the white matter, where the trajectories of the white matter vectors is in opposite directions as you approach the interhemispheric fissure. And depending on the orientation of the coil, you could have differential effects on the left or right visual field. And so we think that it's possible to activate well, actually, I think it's very likely that part of what activates during TMS is the immediate subcortical white matter.
Thank you. Prachi, you're next.
Yeah, hi. Thank you for the wonderful talk. I was just wondering if you do you use TMS for status in the ICU?
We do. So we do it at Children's. The Brigham and Women's Hospital seems to like us a lot, and they call us quite a bit to their ICU for patients with epilepsy partialis continua. So for EPC, actually, we've used TMS quite a bit. I should say it works about a third of the time. That is that roughly the patients that we've exposed to repetitive stimulation for EPC break into about a third where EPC stops, and it's pretty dramatic when it does. About a third where it pauses for a few minutes and then relapses as soon as you stop stimulating. So it's not a meaningful result. And about a third where nothing happens no matter what we do.
Atif?
Thank you.
Thanks, Alex. That was great. Can you update us very quickly on where the clinical trials stand with refractory epilepsy? And is it TMS or TDCS, or do you see a near future where these TDCS devices that are now commercially available can be used for seizure control?
Yeah, so TDCS, I think, is a little bit ahead of TMS in terms of clinical trial. Full disclosure is I'm the PI of the FDA pivotal trial for a company that manufactures a TDCS device. And TDCS, transcranial direct current stimulation, is another form of non-invasive transcranial stimulation where cortical excitability is modulated by very low amplitude but prolonged direct current. And it turns out that if you put a cathode over somebody's scalp, in the region of the cathode, but not the anode, there is lasting suppression of cortical excitability. And that modulates seizure susceptibility, as you can imagine, in a few trials. And there's a big one in progress now. I would say it's about 2.5 years out from completion. If it works, this would be in many ways a better option than repetitive TMS, where the magnitude of seizure suppression has been about the same as TDCS, but the TMS device is cumbersome and expensive, and TDCS is something that in principle be done at home eventually. The trial that's ongoing, and we really would welcome participants, is for an in-hospital application, but from many of our perspective, this would be a device that would eventually make its way home.
Wayne, do you have a comment?
Yeah, so thanks for the great talk. I am a stroke neurologist here at runs a neuromodulation lab. It was very interesting to see it seemed to me the epilepsy, for some reason, keep the lesional motor cortex in the development stage because the ipsilateral cortical spine tract just didn't retract.
Right.
Is there any way you do some resection, you can help, or neuromodulation, you will be help with the resolution or reduction of the ipsilateral? In this way, you can still promote the motor precision.
We don't know. So it could be pharmacologic, something that we have to do to help with motor precision. And even beyond that, I think to avoid crowding in an already compromised hemisphere in terms of function. So for us to do neuromodulation, we would have to find distinct topographies for the ipsilateral and contralateral tract, and that's been very hard. We've looked, and what we find is that unfortunately in epilepsy they're overlapped.
I see.
So our thought is that the approach to this might have to be pharmacologic. Now, the approach to this might also be just seizure suppression. That could be the pharmacologic approach. But you're right, it would be terrific to selectively stimulate the tract you don't want, depotentiated, but we've not been able to find the right kind of topography for that. But I'm glad we're thinking along the same lines. Yeah.
Thank you.
All right, Alex, thank you very much. It was just a wonderful talk. John Sampson, the head of neurosurgery and the physician practice here, sent me a text saying that it was an incredible talk. I didn't even know. It's probably the first time John has ever tuned into Neurology Grand Rounds.
That's very kind. Thank you.
Anyway, have a great day and bye, everybody.
Thanks a lot, guys. Bye, everyone.
Thanks, Alex.